Hello everyone. Today I'm going to teach you about the respiratory distress syndrome. RDS, also known as neonatal respiratory distress syndrome. RDS, it is the most common cause of respiratory failure in the preterm infants. It was formerly known as hyaline membrane disease. The risk factors for RDS are prematurity, perinatal asphyxia, chorioamnionitis, infant of diabetic mother, and hydrops fetalis. This disorder is mainly caused by deficiency of pulmonary surfactant in an immature lung. Inadequate surfactant activity in a premature lung results in high surface tension, leading to instability of lung at end expiration, low lung volume, and decreased compliance. These changes in lung function causes hypoxemia due to mismatch between ventilation and perfusion. Surfactant deficiency also leads to lung inflammation and respiratory epithelial injury, which may lead to pulmonary edema and increased airway resistance. These factors further exacerbate lung injury and worsens lung function. Surfactant is a surface active material produced by type 2 alveolar cells. Surfactant synthesis begins at 24 to 28 weeks of gestation. The clinical finding of RDS will include the tachypnea with the rate of greater than 60 per minute, expiratory groaning and nasal flaring, sternal and intercostal recessions, and cyanosis. On physical examination, auscultated breaths, sounds are decreased, and infant may be pale, with diminished peripheral pulses. In severe disease and in very premature babies, signs and symptoms appear in labor room, and they need positive pressure ventilation. In mild to moderate disease, symptoms appear gradually within hours. The investigations of RDS include: 1. Arterial blood gases to check hypoxia and acidosis. 2. Chest X-ray that will show diffuse reticulogranular ground glass appearance with air bronchogram. 3. Septic screen to rule out early-onset sepsis. And 4. Blood sugar levels. This is the typical X-ray of an infant with RDS that is showing reticulogranular ground glass appearance with air bronchogram. The clinical diagnosis of RDS include tachypnea, chest retractions, cyanosis, and a characteristic chest X-ray. The differential diagnosis of RDS include transient tachypnea of newborn, pneumonia, pneumothorax, and cyanotic heart disease. The management of RDS includes supportive and specific care. The supportive management includes maintenance of neutral thermal environment, monitoring of oxygen saturation input and output record, and treating metabolic acidosis with sodium bicarbonate. The specific management of RDS includes giving warm, humidified oxygen, continuous positive airway pressure, intermittent positive pressure ventilation in case of respiratory failure, and surfactant replacement therapy. The complications of RDS include pneumonia, bronchopulmonary dysplasia, pneumothorax intraventricular hemorrhage, and patent ductus arteriosus. Appropriate management of high-risk pregnancy and labor and administration of dexamethasone to women 48 hours before delivery of the fetus between 24 and 34 weeks of gestation can decrease the severity of RDS.